Hello, and welcome back to another edition of Nice Living with Dr. Cameron. I'm Amy Bowen, and here with me is one of North Carolina's most trusted physicians, an expert in the treatment of vein disease and venous insufficiency, Dr. Kamran Goudarzi. Dr. Cameron, such a pleasure to be with you here again.
Thank you very much. Feeling is mutual.
Well, Dr. Cameron, this episode is dedicated to our friends that are primary care providers. And continuing on our podcast for the last episode, we were able to talk a little bit about vein disease symptoms and a little bit about some of those causes and risk factors of vein disease. And today, we wanted to dive a little bit deeper into some of the visual symptoms of vein disease. So let's start with one of the topics we were talking about previously from that standpoint of a patient coming in complaining of swelling legs, and this potentially being tied to vein disease. This is visual as well. But I'm curious if in your history of treating vein disease, if you see any of this tied to happening with women more than men. We know vein disease is much more prevalent in women than men as it stands. So tell us a little bit more about that.
Very good point. So, of course, we were just talking about, symptoms, and the visual effect is very much of a symptom. So, but, to a point, I mean, you could look at somebody's leg and they might not even have any visual veins. So visual can definitely confuse you. Some patients have, "Well, do I really have venous insufficiency? Because I don't see anything." And I like to compare it to the Titanic. I say, all I see is that little iceberg, there's otherwise everything is fine. But if they had an ultrasound and then looked under the water, Titanic would probably have been still been here. Venous disease is very similar. Just because you don't see much on the surface or just a little bit on the surface, you really got to get an ultrasound to see what is underneath it. So does it affect women more? Yes, it does. It's much more common in women. And it's still, we're trying to understand venous insufficiency. It's kind of complicated because our patients have varicose veins all their life, doesn't cause any symptoms. I have other patients, I've got one lady who's just in her early 30s, and she's already got severe, what we call venous dermatitis, and the skin is about to break down. So why is this person doing this, another one doing something else? So we know a little bit about the pathophysiology of this condition. We know that it does cause an inflammatory reaction. We know that, for example, one study I read is it only seems to affect the veins of the lower extremities when they become varicose. So in one study I read, there were estrogen receptors on the superficial veins where they get varicose veins in the leg, which were like 1,000 times more than they are anywhere else in the body. So why is that? Why we have estrogen receptors? But that is important because estrogen receptors, when you have a level of estrogen, the vein expand. So a lot of people who have venous insufficiency, they tell me that when they're having the periods, the legs start swelling, getting achy. So that's what it is. The veins expand. Or during pregnancy, they get varicose veins or venous insufficiency gets worse. They say, well, it's because I gained weight or, force of the uterus on my pelvis, on my vena cava. No, that's not necessarily true because we know that the veins start getting bad as soon as your urine turns positive. So the recommendation is start wearing compression stocking when your urine turns positive. At that time, the uterus is not even big enough to push on anything. You haven't gained so much weight to even push on anything. So it's hormone related. So we know hormones are responsible. If hormones are responsible, then quite understandable that women are more prone to getting it. The men, in all fairness, they also, even if they have it, they don't usually complain about the men, like to live with everything, and they're not very good in trying to get treatment. And I have this theory, it's one of the reasons men die younger than women. I don't know, they're scared of doctors or they don't believe in preventive medicine or they just want to live with it. It's just too much or they're going to ask for help. So is venous insufficiency just as prevalent in men? I guess we'll never know that. All I can tell you is a lot of literature shows that when we see men, their brains are usually a lot worse, and a lot bigger, a lot larger, much more of a challenge to be treated. Obviously, to your point is hormonal effect. Yes. Genetics. So if they ask me what are the three reasons for getting it, I said genetics, because those three things are very important. So if you get swelling, then what can swelling cause? Swelling itself stretches the skin, then they get some redness. I've had patients who come in and they say, I've got cellulitis of my legs. They go see primary care physician, I'm going to go to the ER, and they're put on antibiotics because they think it's an infection. No, it's an inflammation. Inflammation is just like an infection, except there's no bacteria. I've noticed severe edema can cause that erythema, that redness around the ankle. Venous insufficiency itself can cause venous dermatitis. So if a patient walks to your office as a primary care physician, what are the signs that they have patient venous insufficiency? Well, some of them are very obvious. That's called lipodermatosclerosis. I mean, they walk into your office and from the knee down, it's all discolored. The skin is almost leathery, dark discoloration. That is classic. That's untreated venous insufficiency. Sometimes I'm in Costco or something, I'll see people walking with their shorts on. You can see they've got all this dark pigmentation around the ankle. Sometimes it comes all the way down
Yeah.
to the knee. This poor guy's got venous insufficiency. Okay. So that is very advanced venous insufficiency. Again, we've got some of these pictures on the Facebook, and that's, I think, one picture is worth 1,000 words. I believe on the Facebook, I had pictures of cases of severe venous insufficiency, and there's this lipodermatosclerosis picture there, which is very classic. They very briefly, lipodermatosclerosis. Lipo means fat, derma means skin, sclerosis means the scarring off. Again, it's an intense inflammatory reaction caused by venous disease, and they end up getting the skin really poor. It's actually very painful. She has to use topical lidocaine for pain. The dark pigmentation, the thickening of the skin, that is advanced venous insufficiency. You might have a rash on the inside of your ankle, and there are four perforators. Perforators are veins, little channels which connect the deep system to the superficial system. And there's four of them called the coccus perforators just above the medial aspect of the ankle. So there's a lot of pressure there. There's different theories why they get it there, but it's classically some itching, or some redness in that area. And then if not untreated, it advances to ulcers and it gets shallow ulcerations and then advanced ulcerations. Again, I've got some pictures of that on the Facebook because they show you some cases of venous dermatitis. And there are pictures of venous ulceration, some tiny ulcers inside the venous dermatitis, and then some really large ulcers. And then when they're treated, you can see that the venous dermatitis goes away, the ulcers heal. So from that point of view, it's very satisfying because you've got a leg ulcer, you treat them, and it's gone. Once upon a time, I used to do a lot of vascular surgery, arterial work, and I used to think everything was arterial. And because we didn't know enough about veins. Now we know about veins, I find out that, in my opinion, the majority of ulcers on the legs are venous in origin. I remember last time you and I were talking, you were mentioned the word diabetes. Diabetes doesn't cause the ulceration on the medial aspect of the ankle, but diabetes, if you get an infection, it's very hard to treat that infection. So you've got venous insufficiency, you've got venous ulcer, you've got diabetes. That also gets deep enough, gets into your bone, you get osteomyelitis, and now you could end up with an amputation if you're diabetic. So it is important to know about that. So we talked about rash, we talked about the itching, we talked about ulceration, lipodermatosclerosis, swelling. We talked about that. If you see the legs is swollen, then probably they've got some venous insufficiency. The venous dermatitis, although very commonly, almost always happens on the inside of the ankle. I have seen patients with varicose veins with a rash on top of it. Patient we presented in Florida had a varicose vein on his thigh. It was a guy had a varicose vein on his thigh, and there was a rash right on top of it. And he'd had it for 3, 4 years. In fact, he was convinced that he got the poison IV. And I'm like, okay, why 3 years? 3 years. I don't know, but that's when it started. So people always try to find what in their mind makes sense. But no, it was the varicose vein that causes dermatitis. So when I closed the vein, the rash went away after 3 years. So talking about venous dermatitis, one thing I really see is very commonly from internists, family practitioners, even dermatologists, is a patient shows up with a rash on their leg and they think it is just dermatitis. They don't know it is venous dermatitis, so they start giving them a steroids. Topical steroids, of course, it helps because it is an inflammation, but as soon as the steroids to stop, the rash comes back. I had this one lady literally last week who was actually put on oral steroids, and she's like 30 years old. And that is a lot. It causes salt retention, makes you prone to getting diabetes, and it decreases your immunity. So you're not taking care of the source of the problem. So it's going to keep on coming back. So these are the things, right now I can think about as far as the signs are concerned.
So, As you're pinpointing these different signs and symptoms, what's the next phase and really definitively determining that diagnosis?
So honestly, as they say in medicine, 90% of the diagnosis is made based on what the patient tells you. So the patient comes in and says, Mom had venous disease, horrible. Or not too bad, but he had it. Dad had it. And I have cramps in my legs. And um, it wakes me up at night. I have to walk it off. And when I'm on a plane ride, it gets really bad. It gets really sore. And I'm only 30 years old. I'm very healthy. Don't have any medical condition. What she's telling me in a medical language, I have venous insufficiency. Then the physical exam is a confirmation. So you look at the patient, see, well, yeah, you've got some edema, you've got some early lipodermatosclerosis, or you've got venous dermatitis, you've got a rash. So that helps you make a diagnosis. And then, of course, you have to confirm it with a test. And the best test is an ultrasound. Ultrasounds are very accurate. Just as soon as you put the ultrasound in the leg, you can tell that, usually these veins are large. They show some reflux. You can tell almost immediately that's what they have. And then my recommendation is do a proper venous ultrasound, which means we call them mapping. They have to look at the deep system, make sure they don't have a clot. Because remember, you could sometimes have varicose veins just because you have a clot in the deep system. I compare it to I-40 and I-40 bypass. So supposing you're going from Wilmington, North Carolina, since we are in North Carolina, to Raleigh, and you get an I-40, you're there in no time, 75 miles, 80 miles an hour, you're there. Now, if you try to get to Burgo exit, all these side roads, it will take you forever to get there. These superficial veins are like the side roads. Now, imagine there was a car accident on one of those side. That's when you have incompetent valve. The traffic is not moving or moving very, very slowly through these side roads. So it might take you 7 hours to get to Raleigh. So the blood from your foot, which is Wilmington, to your heart, which is in Raleigh, instead of 2 hours,
Hmm.
it's taking just 7 hours. So the flow diminishes. Now, by the same token, you want to make sure the deep system is fine before we treat these patients, because if you have a clot in the deep system, if I-40 was blocked, then all the traffic would be going through the side roads. So the side roads would be very congested. And you don't go and take care of the side roads without knowing that the main road is open. So don't go and close the side roads and tell everybody to go into I-40, because now nothing is going to get to Raleigh. And that's very dangerous. You're going to literally lose your leg if you block all the venous drainage system. I would have a very low index of suspicion for deep vein thrombosis. You can miss it very easily. I have live and breathe veins from sunrise to sunset. So I've seen things. So I worry, and it's so easy for me to do an ultrasound. So if you have a swelling in your leg, just don't say, okay, I've got a diagnosis. It's very sufficient. Another thing we didn't talk about is superficial phlebitis. We all know, all the primary care physician know what superficial phlebitis is. It's one of those varicose veins, just thrombosis, and it gets red and tender. By the way, please don't put them on antibiotics because it's not an infection. Traditionally, when I was in medical school, and still to this day, unfortunately, majority of physicians are taught, unless that's changed like last year or two, medical school, just put a heat pad and tell them to take some NSAIDs, ibuprofen or leave wrong. You have to do an ultrasound, in my opinion, in these patients, because about 30% of them in one study I read could have clot extend to the deep system.
Mm.
Have you missed that? You missed the deep vein thrombosis. So, I had a patient just like that a few years ago, had two clots. And thank God he came and saw me, because that's clotted his lungs. It would have killed him. So if you get phlebitis and you go to a primary care physician, please do not tell them to take some, ibuprofen and put a heat pad. Make sure you send them for an ultrasound, so you show this clot does not exceed the deep system. I mean, it's superficial. And then I would still encourage them to be treated by their vascular surgeon or the vein surgeon, because there's a lot of ifs and buts and maybes. How far is it from the deep system? If it's more than 10 centimeters, I don't worry too much. If it's less than that, I get a little concerned. And that becomes more the art of practicing venous insufficiency. And unless you deal with it every day, I think probably it's a good idea to just send them to somebody who was aware of it. But superficial phlebitis should be a red flag. And that's again another physical sign which we haven't talked about. Sorry about to being so long-winded there, but
That's really interesting. I mean, I can remember from, a patient standpoint after having a procedure and having an area after I had the IV removed, having some significant redness and swelling in that location and kind of a knot that just didn't go away for a couple of weeks. So something like that, that's probably something I should have gotten checked out.
Yes, so that is classic superficial phlebitis, but it is provoked. The IV actually caused that. So in the arm, you can also get infection. Bacteria can get in. It's called suppurative phlebitis, which, most people can try to drain that. But 99% of the time, in my opinion, it is superficial phlebitis caused by the IV. You take the IV out, put the patients on aspirin, they could better. But you said, like, Cameron, what would you do? I believe you should do an ultrasound because whether it's a cephalic vein or a basilic vein, if you have to follow that, make sure it doesn't go all the way down to your subclavian vein because that subclavian vein is or axillary vein or deep veins, and they can potentially go from there into your lungs.
Mm.
So ultrasound is so easily producible and so easy to look at. And look at it, say, okay, does this stop here or does it go all the way down? And if it's going all the way down to subclavian, then we better start treating it with some blood thinners or whatever you need to do.
You learn something new every day.
Yeah.
Well, Dr. Cameron, we've talked about all these red flags from the visual signs and symptoms of vein disease. Next step, when it comes to treatment options and next steps for patients, if they're presenting with these options, talking a little bit about where to go next, would love to know what you would recommend for primary care providers from this standpoint.
My ultimate goal is if I could educate this art of venous insufficiency to let the primary care physicians know that, if you have leg cramps, if you have swelling, if you have venous dermatitis, always in the back of your mind think this could be vein related. If you could do that, I think it's great. So the next thing is, okay, what do I do with this? Do you want to treat it yourself or do you want to send it to somebody? And nowadays, there's quite a few vein centers. My recommendation is make sure they're vascular surgeons or at least general surgeons with some vascular, interest with specialty, and they're familiar with venous disease because medicine has become super specialized. It really has. I think it was one of the first ones to sit for the exam for the venous insufficiency. And usually arterial should cover everything. But then I've noticed it's really super specialty. Although you know about arteries, you don't know enough about superficial veins. And although it's an obvious procedure, you need to have vascular ultrasounds. Vascular ultrasounds are very familiar with it. As a surgeon myself, I have to get familiarized with doing ultrasound. So you really are ideally want to send them to vein surgeon to evaluate and tell you what's going on and give you feedback. There is one thing you could do once you've confirmed that this is not a clot, then you can certainly try compression stock. Make sure it's medical grade compression stocking. Recommend to get a baby aspirin, though there's some controversy there. I think 81 milligrams of aspirin helps. If they're going on a long flight or the job involves sitting a long time or they're going to be a plane ride, I tell them to take a baby aspirin. Make sure they wear a compression stocking, especially in the plane, because that's one area people do get clots. I think it'll kill you if it goes to your lungs. It's obviously very dangerous. It's so easily treatable. And that's so sad because it is, some young people can die, from clots for that. So stocking,
Wow.
now you try the stocking, and you're not getting the result. You can send it for a consultation. We are here in Wilmington. You can send it to us. You can send it to other pain centers that you're, comfortable with, and they can check it and tell you what the diagnosis is and then what the recommendation is for the treatment is. The treatment is really uh, a little bit of lifestyle change, although it doesn't make that much difference. If you're sitting for a long time, make sure you use your calf muscles. Try to stand and use your calf muscles. Standing, sitting all the time, they both are make you prone getting venous insufficiency.
So extreme one way or the other.
Right. Your calf muscles are your heart for your veins. 90% of the blood gets out of the leg through the action of your calf muscles. So you really want to use the calf muscles. Biking, walking, running, they really help. Weight reduction obviously helps. If you're doing a lot of weightlifting, you really want to have compression stocking because once you lift, it pushes all the blood back into your leg, can make it worse. But these are, some of the, examples of what you can do if you've, of course, got deep vein thrombosis, you've got clots. That is the vascular surgeon hopefully can tell you if it is something that they can nowadays, they can balloon them, they can extend them, they can stretch it. So there's all kind of things available. Once you made a diagnosis, the treatment usually is easy. As one of my professors used to say, people always look for a treatment, just keep on shopping around to find out who is the best person who can treat them. I say it's never the treatment, it's the diagnosis.
Mm.
Once you made a diagnosis, treatment is simple. So once the diagnosis of insufficiency is made, the treatment options are very easy.
Well, Dr. Cameron, it's a pleasure as always. We look forward to connecting again for another episode of Nice Living with Dr. Cameron coming soon. And again, next episode, we're going to be talking a little bit more about those signs and symptoms of vein disease to look out for with dermatologists as well.
Thank you so much again. I appreciate it.
Absolutely. For all of our listeners, of course, you can find Nice Living with Dr. Cameron online at scarlessveincare.com. That's scarlessveincare.com. Just click the little podcast icon. You can catch up on past episodes and you can catch up on all the current episodes as well. And you can subscribe wherever podcasts are found. Just check it out on your favorite listening platform. You can find it on iTunes. You can find it on Amazon as well. You can even ask Alexa, just play Nice Living with Dr. Cameron, and it'll come right up. We'll talk to you again soon. I'm Amy Bowen, and of course, Dr. Kamran Goudarzi, pioneer in vein disease and venous insufficiency. Thanks so much again.